I wish people knew about these conditions before it was too late. Some of the most devastating eye conditions are avoidable with the right knowledge. Today, we're focusing on lesser known but still common eye conditions that are related to age that we don't really hear about until they actually happen. Let's bring them to light so you know what to look out for. Let's start with the most common condition on our list because it affects over 75% of people above age 65. That would be posterior vitreous detachments. A posterior vitreous detachment happens when the gel that fills the eye pulls away from the back of the eye, the retina. It is typically closely attached to this area, so as it detaches, there can be some tugging, which can put the retina at risk. I'm going to talk about some of the potential complications of a posterior vitreous detachment now and a few more later because they can actually lead to one of the other conditions that I want to touch on today. But what's important to understand for now is that a posterior vitreous detachment happens because the gel in the eye changes as we age. This is a normal part of the aging process. That's why we see so many people above the age of 65 with this condition. What can be bothersome about it is that once the vitreous pulls away from the back of the eye, it tends to leave a pretty dense fibrous floater that you can see darting around in your vision. Usually for some people this will fade and become less noticeable with time, but it is always going to be there inside of the eye for the rest of our lifetime. And I talk a little bit more about what treatments are available for floaters in another video that I'll link below in the description. PVDs on their own are not dangerous to the health of the eye, but they can lead to other complications. In the process of this gel detaching from the retina, it can tug on it enough to create little holes in the retina or even a retinal detachment. And if someone just gets a hole but doesn't get it taken care of right away, then that can develop into a retinal detachment. This is when the fluid of the eye gets behind the retina and starts to pull it away from the back of the eye. And when you have a retina detached from the back of the eye, you have areas of missing vision. This often starts peripherally, but it can spread to affect more of the eye's area, and that can include the macula, which is responsible for central vision. There are surgeries to correct retinal detachments, but it's rare to get vision totally back to normal. You can be left with distortion, chunks of vision that are missing, reduced visual acuity, and sometimes really poor vision centrally. This is why seeing an eye doctor when you initially have changes in vision is so important, and why follow-up is important as well. When we initially see a posterior vitreous detachment, it's a clear gel. We can often see that large floater that pops off, but otherwise we can't tell if the rest of the vitreous is still attached to the retina or not. So we tend to follow up within a few weeks, usually a 6-week period of time, to make sure that everything is still intact in the retina, to make sure that a hole or a tear has not developed, as we can't always tell when the vitreous has fully detached. Once it's been, a number of months, we can be pretty confident that further changes aren't going to occur and that the risk of these complications is lower. So what's really important to look out for this condition are flashes of light in the vision, brand new floaters, and especially if there are changes in the vision, peripheral visual field loss, distortion in the vision, anything that appears out of the ordinary, you should see your eye doctor right away. So even though there's no way to avoid a posterior vitreous detachment, since it is a normal change that occurs with age, we still need to pay attention to these symptoms to be sure that a further complication does not develop. I wish people knew about these symptoms before they happened and how important it is to be seen right away, because if one of those complications is there, it's very important to treat usually within 24 to 48 hours to prevent loss of vision and progression of the condition. Studies show that 10 to 20% of people above the age of 65 have epiretinal membranes, aka macular pucker, aka cellophane maculopathy, aka surface wrinkling retinopathy, and during this part of the video, I will be calling them ERMs. An epiretinal membrane is aptly named because it happens when there's a thin layer of fibrous tissue on top of the innermost layer of the retina, and when this contracts, it pulls up on the retina, causing it to wrinkle. This can cause symptoms of blurry vision. They typically range between 20/25 and 2200 on the visual acuity chart, and metamorphopsia, which would be wavy or distorted vision. Avoiding ERMs can be tough because we don't always know what causes them. There are, however, some things that may make an ERM more likely, like a posterior vitreous detachment, like we were just talking about. The tugging on the macula by the vitreous as it detaches can sometimes cause some micro trauma and inflammation that leads to this fibrous tissue growth that contracts and pulls on the retina. Other things that may contribute to an ERM would be retinal tears or detachments, inflammatory eye diseases like uveitis or retinitis, diabetic retinopathy, eye trauma, or a history of eye surgery, which would usually be retinal surgery. So protecting the eyes, seeking treatment promptly for signs of infection, inflammation, posterior vitreous detachments, retinal tears, retinal detachments, and controlling diabetes from the outset could help you avoid an epiretinal membrane. Unfortunately, there isn't any evidence showing that supplements or certain diets can help to prevent or improve this condition. That's where it's really important to pay attention to what the condition is. Someone might hear macula and think macular degeneration, and there are supplements that are recommended for that particular condition. But just because it's in the macula doesn't mean it's the same. In fact, these two conditions involve very different layers of the macula, so supplements that help in macular degeneration do not help in epiretinal membranes. The treatment for an ERM is a vitrectomy with membrane peel. This is where the gel is removed from the eye and then that thin fibrous membrane is removed from the surface of the macula. Because of the delicate nature of this procedure, most are lucky to achieve vision of 20/40 or better after the fact. So this plays a huge role in determining who should have surgery for the ERM and who shouldn't. If the vision is better than 20/40, usually surgery won't be recommended because that vision is actually better than what can typically be achieved with this surgery, because there is a potential to damage that retinal tissue in the process. If vision is worse than 20/40, or if there's a particular issue with lots of waviness or distortion, the surgery may be recommended. There's a lot of conversation that needs to be involved. Informed consent is really important here, and a discussion with your particular eye care provider and eye surgeon. Now, that is the general rationale behind this procedure that I think will be helpful to understand if you're trying to navigate this situation. ERMs tend to stabilize over time, but they can progress. And in some rare cases, they can even progress to macular holes, which is where the central tissue of the macula, where it's the thinnest, fully separates. And the range of visual acuity here is very variable, between around 20/25 to sometimes just counting fingers, which means you can only count fingers at certain distances. And this affects the central vision. So the peripheral vision will still be intact, but this can make it very difficult to see detail, faces, read, do day-to-day activities. This is one of the reasons it's a good idea to follow up with the eye doctor to monitor for any progression of the epiretinal membrane, because if early changes are noted and it looks like a macular hole may be pending, then that may change the treatment plan a little bit. Again, macular holes are really quite rare, so the moment an epiretinal membrane is diagnosed, I wouldn't jump to have surgery just as a preventative of that, definitely not. But just another important reason to follow up and make sure that everything is stabilizing. Retinal vascular occlusions are relatively uncommon, affecting about 1 to 2% of those above age 65 if you combine all four types. But I still think they're really important to talk about because the vision loss that can occur can be devastating and permanent. And with proper health maintenance, could have been avoidable in a lot of cases. That's because common risk factors for these conditions include high blood pressure, high cholesterol, diabetes, arteriosclerosis, atherosclerosis, cardiovascular disease, carotid artery disease, and embolic disorders, most of which can be avoided or controlled with proper diet and exercise. It's worth noting here that Viagra and other erectile dysfunction medications can double the risk of a retinal vascular occlusion occurring, but I get much more into that in a separate video that I'll link in the description. There are 4 types of retinal vascular occlusions that are broken down by which blood vessels are affected: the central retinal artery or a branch off of that artery, the central retinal vein or a branch off of that vein. Arteries bring blood to the retina, so when an artery is blocked, that part of the retina that it feeds is not receiving oxygen. That blockage of the blood flow leads to tissue death. It's a little bit different for the veins because that's taking blood from the eye. The eye has already been fed in that area, but a blockage in the vein tends to lead to leaking of that blood vessel, and we see a lot of blood inside of the eye. These don't tend to damage vision as much as an artery blockage because the retina still is receiving that oxygen and that tissue still functions. But all of these can lead to complications, though the severity really varies depending on which blood vessels are affected. If a vascular occlusion does occur, the treatment is likely to vary based on the type of occlusion. A central retinal artery occlusion is considered an ocular emergency. So if your vision ever suddenly goes black, you should call your ophthalmologist right away and start heading there before they even pick up the phone. Long-term complications of any of these occlusions could include the growth of new blood vessels called neovascularization, and these new blood vessels are trying to help by providing more oxygen to the eye, but they end up leaking a lot more and causing a lot of other complications, and this can lead to a lifetime of necessary treatments in order to keep these complications at bay. This neovascularization can occur months or even years after the fact, so it's really important to monitor the eyes if this does occur. And this neovascularization may require a lifetime of maintenance treatments with lasers or intravitreal injections. Conditions like this are age-related because they happen at a later age, but they occur because of a lifetime of bad to subpar health choices. We should be protecting ourselves by protecting our vascular health from childhood on by maintaining healthy lifestyles, including diet and exercise. Diabetic retinopathy is a growing concern because the rates of diabetes continues to increase. An estimated 10 to 15% of people above the age of 65 have diabetic retinopathy, but that's just in the general population. 30 to 40% of those with diabetes above the age of 65 have diabetic retinopathy, and this occurs for both those with type 1 and type 2, but more commonly in type 1 because that is diagnosed at an earlier age, and diabetic retinopathy is more likely the longer you've had the disease. This matters because diabetic retinopathy involves bleeding, swelling, and ischemia, lack of blood flow inside of the eye. And a lot of these symptoms start mild and don't affect vision, and they're not visible from the outside. So this can actually be worrisome because people can be going on for years if they don't get regular eye exams, not knowing that this is going on inside their eyes until it gets to a pretty severe stage. As it progresses, it can cause vision to become blurry, distorted, or cause areas of vision to go missing. But that's not the worst of it because it can lead to some serious problems, including retinal detachments, scarring, and a certain type of glaucoma that's very difficult to control. Treatments for diabetic retinopathy range from simple blood sugar control early on to laser or intravitreal injections later on in the disease process. The downside is, despite these treatments, once the progression of diabetic retinopathy has begun, it can be difficult to control, particularly once it's reached a severe stage. This is why prevention is key. I wish more people knew what diabetes is capable of. From the initial diagnosis, controlling blood sugar with diet, exercise, medications, and monitoring blood sugar as directed is going to be huge to prevent or postpone the development of diabetic retinopathy. Even better, avoiding diabetes in the first place can prevent all of these troubles to begin with. Not necessarily for type 1 since we don't know what causes it, but type 2 in most cases is preventable. Many of the risk factors for diabetes are at least in part preventable or controllable, like obesity, lack of exercise, poor diet, high blood pressure, high cholesterol, and smoking. It would truly make me so happy if even one person saved their vision by preventing the development of diabetes after watching this video. Did these conditions take you by surprise, or have you experienced them yourself? Be sure to share with a friend so they can be on the lookout as well. And don't forget to like and subscribe if you enjoyed this video. For part 1, go ahead and click here, and I hope to see you again. Thank you so much for watching.